Hello, friends. I would I would like to talk about subjective halitosis, its subclasses and its clinical forms. But before all, we need a good description and a proper classification of halitosis. Halitosis is receiving increasing scientific interest, but no accepted definition exists. There is no universally accepted precise definition, nor standardization in terminology and classification of halitosis. In the literature, definitions include the subjective perception after smelling someone's breath if unpleasant. This is too simple and insufficient definition. I would like to share my screen. Yes. Yes. Such simple definitions ignore the potential origins of malodor. For example, emission of odors via the mouth or nose, from the respiratory or gastroesophageal tracts, etc. Moreover, none set a clear boundary between normal and pathologic halitosis. In 2014, I have described the halitosis. According to my definition, halitosis can appear humans and animals, not only humans, but also including animals. Halitosis is emitted from the mouth, nose, and breath. There are three doors of emission halitosis. I didn't say three origin. I said three doors emission for emission. Halitosis can appear at any time of a day, not only morning breath. No need for infection or inflammation. Enhanced bacterial activities can cause halitosis. No need infection. Halitosis continues for at least 2 months. None of halitosis types, none of halitosis clinical forms are acute. All halitosis forms are chronic. Halitosis is endogenously produced. For example, garlic does not cause halitosis. Garlic causes garlic odor. Onion does not cause halitosis. Onion causes onion odor. Smoke and cigar does not cause, they cause cigar or smoke odor. Halitosis is recognized from social distance, approximately 1 meter or lesser. Malodors felt when spouses or people are kissing are not pathologic halitosis because odorant gases are resolved in the saliva. Thus, every saliva has malodor, less or much, but it is normal. It is not halitosis. Halitosis should be determined as bad by the patient or his social environment. There are some background odors in some mouths. Such odors are not bad. If we can define halitosis, patient or his social environment must be defined the odor is bad. Classification of halitosis, there are two major classification in the literature. Most popular one, Miyazaki 1999 classification. He divides halitosis into three category, halitophobia, pseudohalitosis, genuine halitosis, and its subclasses you see on the screen. There are a lot of problems with this classification. Many mismatching and some chaotic terminology exists with this classification. For example, extraoral pathologic halitosis covers broad division of diseases, then we need to separately handle them in halitosis clinic. We need to thinner slice the extraoral pathologic halitosis in this classification. Next problem with this classification, morning breath is not placed in the oral category, but it is oral. Next problem, pseudohalitosis and halitophobia are excluded from pathologic halitosis, but they are pathologic. According to Miyazaki classification, after a halitosis therapy, after, after a halitosis therapy, if the patient continue to believe they have halitosis, it was classified as halitophobia. This categorizes cases according to treatment outcome, as halitophobia is diagnosed following a treatment fail. But how can these be determined beforehand if they depend on result of treatment? Moreover, this classification is inflexible since multiple diagnoses for one patient are not enabled. The other classification, Tangerman's, in reality, this classification with insufficient categorization of physiologic, pathologic, sinonasal, laryngopharyngeal, gastroesophageal, or psychologic causes. Again, this system does not allow to multiple diagnoses. A broad division into blood-borne and non-blood-borne may be inappropriate in this classification. Next classification, Aydın classification. Yes, this is just me. My classification. I have published it 2014. You can freely download this manuscript full text from British Dental Journal website or my website. Yes, according to my classification, halitosis is divided into 5 classes. Type 1 halitosis takes origin from tongue papilla, classic way. Type 2 halitosis comes from inflammatory gases from inner surface of the airway, from alveolar mucosa until nostril mucosa. Type 3 halitosis, gastroesophageal reflux or gastroesophageal valve leakage means. Type 4 halitosis, blood-borne origin halitosis. Odorants enter the bloodstream, lungs filter them, and throughout with expiration air. This is breath odor, not oral malodor. It's very different. Type 5 halitosis cannot be detected by machines or other people, despite the patient insistently complain from halitosis. We will focus on this halitosis type. But before make zoom on this topic, I would like to correct some terminological concepts. There are unhelpful terms in this area. For example, psychosomatic halitosis. Psychosomatic halitosis describes an odor is not present, but psychosomatic disorders are disorders in which are detectable clinically in reality. There is a great mismatching. This mismatch compel us confusion or a chaos. Next problem, pseudohalitosis means if oral malodor does not exist, but the patient believes that he has oral malodor. Pseudohalitosis implies a physical condition mistaken for halitosis, non-exist, but the prefix term pseudo is used when exist physical entities in medical area. For instance, pseudo-Cushing syndrome, pseudo-obstruction, pseudo-lymphoma, pseudo-Kaposi sarcoma. The term pseudo term means that the problem physically exists. But pseudohalitosis term means halitosis does not exist. This is great mismatching problem. We will dismiss these terms. We don't need such terms. Moreover, sulfurous, fecally, fruity, and ammoniacal urine-like odors are adjective, very subjective terms. For example, I can define an odor like urine, but you can define the same odor as rose or naphthalene or fuel oil or anything, because description of an odor by individuals, it depends on individuals' socio-cultural background. That's deep and different matter. Other terms, non-genuine, psychoolfactory, olfactory depot, these are unnecessary for us. But there are useful terms. they should be revised. For example, self-halitosis formerly means lack of objective halitosis. But new terminology, self-stimulation of olfactory sensor, this greed accordance. For example, phantosmy, chemosensor dysfunctions, etc. The next term, halitophobia, formerly means lack of objective halitosis, but new meaning fear of halitosis. Not halitosis, fear of halitosis. As you see, there is very good accordance with the word and mean. It's just fit. There's yes. Now we can zoom on type 5 halitosis, subjective halitosis. Subjective halitosis can be divided into two categories. First, neurogenic, second, psychogenic. Neurogenic forms of subjective halitosis mostly consist of chemosensor dysfunctions. Healthy people use orthonasal pathway to smell function. You know, this is orthonasal pathway. You see green arrows here. Odorant molecules enter the nose cavity and arrive to olfactory sensor at ethmoid labyrinths, upper ethmoid cells, lamina cribriformis, you know. At some people, olfactory sensors can be congenitally scattered on the throat submucosa, such as retronasal mucosa, nasopharyngeal or dorsolingual mucosal surfaces. These are called ectopic sensors. Ectopic sensors. Ectopic sensors may begin to work at any time of the life with unknown reasons, so that such patients begin to smell with their retronasal or dorsolingual mucosa, not olfactory mucosa. Retronasal or dorsolingual mucosa can smell like snakes. You know, snakes can smell environment with their tongue. Remember? Yes. I can detect such patients with vanillin test. I will show you vanillin test. You know, there are three chemicals. They have no taste, but have a specific odor. N-butanol, vanillin, phenylethyl alcohol. I use vanillin in my clinic. Vanillin is a powder, a white powder. You can find it plenty in markets. Some vanillin powder is placed on patient's tongue surface while he closes his nose with the left fingers. I ask the question to patient, do you feel odor just now? When nose is closed and vanillin contact the tongue surface, if an odor was recognized by the patient, so the chemical stimulus of the tongue perceived as if odor. It means this patient smells with his tongue. This situation is not very seldom, especially in young people. Except the patient, nobody can detect this odor perception. Thus, subjective halitosis arises with this way. Such patients apply to dentists by complaining halitosis. Because of this, we should aware of this problem. Yes, this is this white powder vanillin. Okay, and the second category of subjective halitosis, psychogenic halitosis. There are three phases, episodic phases. There are hierarchically ordering between three phases. Halitophobia, next phase, obsessional, third, delusional phase. Halitophobia is the initial psychogenic form of subjective halitosis that arises when objective halitosis is prolonged. For example, for years. Halitophobia refers to fear of halitosis and is the simplest and earliest form of subjective psychogenic halitosis. It's very different. There are two different diseases. Halitosis, fear of halitosis. They are very different. If you treat only halitosis, patient will not be healed. We have to treat halitophobia if it's together, if it's come together. Most anxiety episodes tend to disappear over the time depending on the severity of the disease of emotional stress. Patients may not require psychotherapy if they receive appropriate halitosis treatment as soon as possible, as early as. Olfactory obsession is the second phase. If halitosis is prolonged without treatment, the next psychogenic form, olfactory obsession, arises. In cases of olfactory obsession, the patient is constantly repeating the behavior or thinking about halitosis, chew the cud or ruminate in the same idea, same thinking. For example, excessively brushing, washing, changing clothes, asking other people about disorder, blowing his palm of hand or to check malodor out, ho, 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 continuously within whole day. Last episode, last phase is delusional halitosis. When olfactory obsession and halitosis are prolonged without treatment, delusional form of subjective halitosis arises. These are characterized by showing reference to other people's behavior. For example, patients begin to think that people ridicule them, escape from them, turn their faces away, put their finger on nose, close their noses with hands, or open windows because of their halitosis. This scenario points to begin delusional halitosis. This scenario is very specific for delusional halitosis. The later two forms, what is two forms? Olfactory obsession and delusional phase. Olfactory obsession and delusional halitosis. Two clinic form is called imaginary halitosis. When I say imaginary halitosis, you understand two clinical form: delusional halitosis, olfactory obsession. Imaginary halitosis can be healed by only psychiatrists. We cannot cure, we cannot treat them. There is, as you see on the screen, there is a sharp boundary between two subclasses, neurogenic and psychogenic. Tell me, what is the sharp boundary between these two? Yeah, I say, chemical stimulus. If chemical stimulus is present on sensors, olfactory sensors, this is the neurogenic form. If a chemical stimulus is not present on sensors, then this is psychogenic form. It means that there is sharp boundary. What is the sharp boundary? Chemical stimulus on sensor. If it is present, this is neurogenic form. If it is not present, it's psychogenic form. Very easy, very logic, and very useful classification. Now, I suggest you some questions for your halitosis patients to pre-diagnose subjective cases. I have published more than 20 questions in this journal you see here, and you can download from my website or journal's website, of course, full text. First question, does any other part of your body smell bad? Olfactory reference syndrome answers yes, especially olfactory syndrome cases answers yes. You know, 25% of olfactory reference syndrome cases complain from halitosis. For this reason, this question is useful to distinguish them. Second, how do you know you have halitosis. Imaginary forms refer to people's reaction. Next question, how long have you had halitosis? Imaginary forms uses templates. Very specific and very standard. Two templates are present. First template, I have halitosis since my childhood. This is template, standard answer. Second template, I have halitosis since I know myself. This is the second template. Next question, do other people have halitosis according to you? Imaginary forms, no, despite they never brush their teeth. Other question, do you complain about your halitosis when you are alone? Psychogenic forms of subjective halitosis usually answers no. Do you have halitosis when your lips are closed? Type 1 halitosis patients answer no. Subjective halitosis patients answer yes. How long has the longest interruption of your halitosis been? This is very useful question. Imaginary form patients answers no interruption, even 1 second. Others gives moderate time or period. Other question, do you self-perceive your halitosis? Psychogenic forms usually answer no. Question, how many particular malodor do you distinguish in your mouth? Psychogenic forms answers always many odor, dozens odors. Question, how long distance do others avoid you? Delusional form cases usually answers few meters or more. I remember one patient, she was talking about 30 or 40 meters across the street. Some people escaped from me from my halitosis, she said. Interesting case, delusional halitosis. Does your halitosis disappear when you put a piece of ice in your mouth? Type 1 and neurogenic forms answer yes. I would like to disclose this question. When the mouth cavity is cooled with ice, odorous gases, if any exist, collapse, thus becoming non-volatile, and the oral malodor, type 1 halitosis, suddenly disappears briefly. While a piece of ice is present in the mouth cavity, taste and olfactory receptors dispersed in the mouth or throat are cooled by the ice. Chemical stimulus of the odorous gases on receptors decreases or less information is transported to the brain. Cooling the mouth is a useful tool for distinguishing chemosensory dysfunction or type 1 halitosis from the other types. Yes, my 20 minutes has just completed. That's all I have to say. Thank you.